Okay, y'all. So first, we're going to talk about our anti-tubercular drugs. So in your book, I am reading under the section that says anti-tuberculosis agents. So when we talk about tuberculosis, we have to first know what it is, what its impact is, and the more we know about that, we'll understand why we're treating it the way that we do. So, in terms of tuberculosis, 1/3 of the world's population is infected with the disease. That's pretty solid. It is not a prevalent disease in the United States, but especially in Asia and sub-Saharan Africa, there's still approximately 1.5 million deaths a year. So, it is still an epidemic in other crowded areas of the world. People who have compromised immune systems, people who have things like HIV, those are going to be your susceptible parties to this disease. When we're talking about what TB affects, it can affect the entire body, multiple organ involvement, but it is mostly a disease of the lungs. So let's see. Again, not prevalent in the United States, only about 10,000 people have it. But people who travel globally can be infected with latent TB. So what happens with latent TB is you can be exposed to tuberculosis. It can live dormant within your body, and it can become active at a later point in your life. So in addition to latent TB, people, walking around having it and being asymptomatic, we can also, it can also develop resistance for that reason as well. So it is caused by the Mycobacterium tuberculosis. It is bacterial infection, not a viral infection, and is transmitted via droplet through sneezes, coughs, etc. So, tuberculosis antibiotics treat the disease caused by Mycobacterium tuberculosis, which mainly affects the lungs. We've talked about that already. Tuberculosis was very well controlled until the 1980s when the appearance of acquired immunodeficiency syndrome, or AIDS, preceded a resurgence of the disease related to the increased numbers of patients with compromised immune systems. Tuberculosis is treated with a mixture of 2 to 4 daily medications simultaneously for up to 1 year. So when we were talking about compliance with our patients, we specifically said, usually you're not on long-term antibiotics. We're talking usually a 7-day regimen, a 10-day regimen, or potentially 6 weeks for your big real deal infections, right? These people are on antibiotics for 6 months to a year. So compliance, you and I aren't finishing our antibiotics at times, and we're only getting them for less than 2 weeks. The people who are prescribed antibiotic therapy for a year, you can understand where compliance is an issue. So you are going to see some different documentation on these drugs. I want you to recognize the drugs, and I want you to recognize the importance of multi-drug therapy. So the reason these people are on multiple drugs is because each drug eradicates the mycobacterium in a different way. One of the medications, ceromycin, prevents tuberculosis from growing in the body. Rifampin, which is another common antibiotic used for this, it is going to work similarly. Rifampin specifically is going to turn the urine orange, and other secretions as well. Sweat, tears, urine, feces, saliva, like a red-orange color. This is not an adverse effect. This is an expected thing that's going to happen with these medications, with this particular medication. So we want to make sure that we educate our patient well so that they don't freak out when they see this red-orange urine in the toilet, or, seeing that their tears are colorful all of a sudden. If the patient wears contacts, then it can actually permanently stain them. So we want to make sure that they're aware of that. And rifampin, like many other antibiotics, will cause birth control to be ineffective. So in terms of the medications that you need to know for tuberculosis, I am on your chart in the back of your book. It is on page 338. So your drugs there are ethambutol, isoniazid, rifampin, pyrazinamide, and cycloserine. Those are the drugs. All of these medications are going to be used together. So we're going to go a little deeper into that right now so you can see in what combination they're given and for what reasons. So we talked about bacteriostatic and bactericidal drugs. So some of them are going to go in and they're going to destroy that cell wall. They're going to kill the the cell wall of that mycobacterium directly. Some are just going to suppress the growth. Because this is such an aggressive disease, or infection, I should say, we want to attack it from all realms so that we can eradicate it completely within the body so that it doesn't come up. When we treat primary TB, we're going to use a combination of 3 or more drugs. For secondary TB, that is an infection that is found outside of the lungs, so it's affecting the lungs and other organs. We're going to use multi-drug. We're going to use secondary drugs. We're going to use more drugs and the more expensive drugs and the drugs that are going to they're going to cost more. They are going to have bigger side effects like we talked about before. They're going to be more toxic. So we're going to treat our patients with the least effective treatment regimen that fits their disease at that time or their infection. So latent TB, going back to that, if not treated, 5 to 10% of people will become active. So we want to treat these people and go ahead and get rid of that likelihood. We're going to treat them with INH for 6 to 9 months. And that is going to be the only drug that they take because it's more of a preventative drug. They do not have active TB. They will have a positive TB skin test, potentially a positive blood test, but when they do an x-ray of the lungs, it will come back negative and they will be considered non-infectious. These are the drugs that I called out to you earlier. This is standard treatment protocol. They are going to be on 4 drugs initially, and then they will wean off of those drugs, 2 of those drugs after the first 2 months, resulting in at least a 6-month therapy of these medications. Sometimes treatment fails due to inadequate drug regimens or noncompliance. Treatment is very individualized based on the susceptibility of the microorganisms. These are going to be the same drugs that you're seeing in your book. For testing purposes, I want you to focus on the drugs that are found in the chart in your book. These drugs are going to cause the same type things that you're going to see in your regular antibiotics, likelihood or potential for allergic reaction, dizziness. Some of the drugs can cause seizures, numbness, or tingling in the extremities. And again, that red-orange urine specifically with rifampin and INH, we're going to have specific liver damage. We're going to pay attention to the liver with those drugs. Let's see. Ethambutol specifically can cause some retinal issues. So that's with the eyes, of course. So we want to make sure that if someone already has cataracts or diabetic retinopathy, that we are paying attention to that and making sure the physician is aware. Isoniazid is a drug that also can interfere with foods containing tyramine, much like the same reaction that we had when we were talking about our MAOI. So we don't want to combine this drug with foods containing tyramine. Rifampin we talked about, vertigo, rash, red-orange discoloration of the body. Believe that is the main thing. So when we're talking in terms of our nursing process, we really want to make sure that these patients are compliant. We want to make sure that they understand the implications of not finishing these antibiotics. We want to make sure that they are using that contraception during these time frames, and that they are if they're actively infected, that they are wearing a N95 mask when they are in contact with the public. So that is it for our lecture on TB drugs.